All right, good morning, everybody. My name is James Baker, and I'm an emergency medicine physician and ACLS instructor since 1995. Thanks for joining us. Today we're going to review EKG rhythms off of the monitor. So these will be dynamic EKG rhythm strips that you will need to know in preparation for the ACLS class. The ACLS classes that we teach are using guidelines from the American Heart Association's 2010 latest guidelines off of this handbook, American Heart Association 2010, or instead of the handbook, you have the provider manual, which again, this is from the 2010 guidelines published in 2011. The purpose of these video classes, these videos, are to allow the students to preview the material before class, so that will facilitate learning and reinforce the concepts that we're teaching in ACLS class. What we teach and what we review today is not a substitute for clinical judgment in real practice. Every patient is a unique case, and many times the clinical situation is dynamic and changing, so clinical judgment does not replace this material. This material primarily is a prep for ACLS class. Okay, so let's go ahead and begin. The first rhythm that we're going to show here on the monitor is a normal sinus rhythm. Normal sinus is defined between a rate of 60 and 100. So you see the rate here is 70. The monitor shows QRS complexes each and every time. It's regular. The R waves are regular. There's a P followed by a QRS each and every time. The QRS complexes are narrow. So each P wave gets through to make a QRS each and every time. This is a normal sinus rhythm. Now if we take a look at the second one here, it's going a little faster. And the rate is faster than 100, so by definition it's a tachycardia. It's hard to see the P waves through here, but they are here. The QRS complexes are narrow. It's regular, and it's going at a rate of 140 or 141. So by definition, this is a sinus tachycardia. In ACLS land, we'll call it, any tachyarrhythmia that looks like a sinus tach that's less than 150, we're calling it a sinus tachycardia. If it's faster than 150, then we're probably trying to show you an SVT, and we'll show you that in just a moment. But this is sinus tachycardia. Another pearl that I'll throw out is, do you ever shock sinus tachycardia? And the answer obviously is no. And the reason why I bring that up is I've seen many students come through, and during the mega code, they get anxious and they want to shock this rhythm. The correct answer is you treat the underlying rhythm, whatever's causing this sinus tachycardia. It can be pain, it can be hypoxia, it could be high fever, it could be anxiety, it could be anemia, it could be dehydration. Whatever the cause of this sinus tachycardia is, you've got to treat the underlying cause. You never shock sinus tachycardia. Okay, we're going to go to the flip, or the reverse. This is slowing way down, and it'll give us a number there. Okay, so it's going at a rate of 35, so it's less than 60. So by definition, this is a bradycardia. If we look at the rhythm closely, we'll see that there's a P followed by a QRS each and every time. So that tells us it's sinus origin. The QRS complexes are narrow, and again, it's slow. Every P wave gets through to make a QRS. There's no loose P waves or P waves that are not conducting, so therefore this is a sinus bradycardia. And in terms of slow rhythms, we're going to go ahead and show you this one. This is very slow. In fact, this is flatline. So this is asystole. Whenever you see asystole or flatline on the monitor, you always have to confirm in a second lead. You can see here on our monitor we've got lead 2. I'm going to go ahead and push lead select, That takes it to lead 3. So we've confirmed in a second lead that this is flatline asystole. So this is an asystolic rhythm. This is a lethal rhythm. So we're going to go back to lead 2. And we're going to show you the next rhythm. Okay, here we go. All right, so we see a narrow QRS complex, but what you notice is that it's irregular. You can see the R waves. Some are short, some are long. It's an irregular pattern. And there's no identifiable P waves in there as well. You see this undulating, chaotic kind of rhythm where the P waves should be. So no identifiable P waves. The QRS complexes are narrow, but it's irregular. That's the key. So this one is atrial fibrillation, or AFib. Okay, we're going to show its cousin right here. So this is a classic sawtooth pattern. Narrow QRS complexes. This is atrial flutter, or A flutter. This one is very regular, and if you count the P waves, the sawtooth P waves, there's probably 1, 2, 3, 4, and then it makes a QRS, and it's consistent in that pattern. So you could say this is a 4-to-1 conduction of A flutter. Sometimes you'll see A flutter with variable block, but this one we're showing you is a consistent 4-to-1 block of atrial flutter. Okay, we're going to go back to the first one we started with, normal sinus rhythm, and we're just going to show you right there. Okay, we'll show you again. Some early beats are popping into the cycle there. Okay, and we'll show you again. The early beats are narrow QRS complexes, and there is actually a P wave that you can see there, right there. So this is simply normal sinus rhythm with PACs, or premature atrial contractions. As opposed to this one, so there we go with that wide complex rhythm that's popped in there. So this is a wide complex ventricular origin extra beat, or a PVC. So this is a normal sinus rhythm showing a PVC. Okay, and we're going to go back to normal sinus rhythm, and we're going to show you something unique. Watch closely. There it goes. Okay, so you see the difference there. This is PQRST, PQRST, but if you notice, the ST segments are elevated. So this is ST elevation. So when we show you this on the monitor, you've got to recognize, those STs look elevated. This could be an ST elevation MI or a STEMI. We need to follow up what we're seeing here with an EKG to confirm the diagnosis of ST elevation MI. Okay, this one we're going to show. Okay, so you see the run of wide complex. Wide complex is there. There we go again. Okay, so we're showing runs of VTAC, so, or non-sustained VTAC. And if you see that, you need to assess your patient, of course, and consider getting an antiarrhythmic on board to prevent those from being sustained VTAC. Like here. So here we go, wide complex tachycardia. It's regular, monomorphic. So this is what we would call VTAC. And whenever you see this on the monitor, the first question you should ask is there a pulse? If there isn't a pulse, then you're going to treat this like Vfib. If there is a pulse, the next question you ask is this patient stable or unstable? This is a prime rhythm. Be sure you can identify VTAC. Okay, here's a new rhythm that comes into view. Obviously, It's a chaotic, quivering type of rhythm. You can't identify any P waves. There's no identifiable QRS complexes. This is Vfib, or ventricular fibrillation. This is the main one you got to know for ACLS class, and the main one we're looking for in cardiac arrest in real life. Vfib, this is the meat and potatoes of ACLS class. This is the one you definitely will be tested on during megacode. This is definitely the one you've got to identify quick. We have a catchphrase that says, when you see Vfib, you must defib, and defib immediately. If you don't act on this fast, this Vfib, or ventricular fibrillation, will get finer and finer and smaller until we get into asystole flatline. And once you get into asystole flatline, it's nearly impossible to recover that patient, to resuscitate that patient. This is a lethal rhythm, but it's the one that we can do something about. If we see it and identify it and act quickly, we can defibrillate this patient and save their life. This is the big one you gotta know. Okay. All right, we're going to slow down here. We're going to go to something a little slower. Okay, so we're back to normal rate of 70, narrow QRS complexes. I see P waves, P, QRST, P, QRST each and every time. But if you notice, the P wave is kind of set far away from the QRS complex. So it's got a prolonged PR interval. If you were to do an EKG or rhythm strip, you would see it's greater than 2 boxes. So a prolonged PR interval is a first-degree AV block. First-degree AV block is a fairly benign block. It's not serious, it's not dangerous, but it's something to be aware of, because if a patient is showing a first-degree AV block, they may be proceeding toward further higher advanced blocks, which are more dangerous. Sometimes this first-degree AV block, the patient is not bradycardic, so just be aware. First-degree AV block, keep an eye on it, and of course with all the bradycardias you're going to ask, is the patient symptomatic or not? Okay, here's the next one. As we're going through, we see a dynamic change occurring. So let's follow this. There's the PQRST, 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 P by itself. So if you follow that PR interval that we talked about in the first one, you see it's longer, 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 and then we have a drop, P wave hanging out by itself. Let's follow it again. So PQRS, 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 longer, 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 drop. So it's kind of giving us a warning as to what's coming, and warning starts with W, and W is for Winky Bach. So this is a second-degree type 1 or Winky Bach type of block. So this one's a little bit more concerning than the first-degree AV block, but still it's usually not too bad. It usually doesn't cause unstable symptoms in a patient. So PR interval, longer, 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 drop, no QRS. This is a Winky Bach. Okay, we'll go to the next one. Now here we have P waves getting through, making a QRS, but then we have Ps that are left hanging without a QRS getting through. So the simple way to think about this is the atria are creating these P waves, but the conduction is not getting through consistently to make the ventricles create a QRS. So we get drop QRSs without any warning. This is a higher degree block. This is an unpredictable block. This is a second degree type 2 or a Movitz type 2 block. This is considered a higher degree block, a little more serious. You need to act on this and be hypervigilant as to treatment, especially if the patient is symptomatic. And finally, here's our next one. And you see the QRS complexes are now wide. You see the P waves are marching through, but it doesn't seem like they really conduct. You might think, oh, there's one that's conducting there, but if you look closely, and if you do what we call marching out the P waves, if you take calipers and you march out the Ps are coming at a consistent rate. And the QRSs, if you march those out, those are happening at a consistent rate. But the Ps are not creating any QRSs. There's a complete block here. This is a third-degree AV block. The Ps are going at their own rate. The QRSs are going at their own rate. There's no relationship between the two. There's no connection between the two. This is a third-degree AV block or a complete heart block. This is the most serious type of block that we've got. Okay. We're going to go ahead and show you a few other rhythms. Okay, so here we see a wide QRS complex with no P waves in front of it at all. It's slow, rate of 35. When you see something like this, this is called an idioventricular rhythm, where there's no Ps. The signal is generated from the ventricles because they're not getting any input at all from the atria from above. This is an idioventricular block. Okay, we're going to go ahead and show you this one. We're going to go back to this fast one. Whoops. Okay, we're going to go back to a fast rhythm here. And the rate is climbing. 150, 160, 170, 179, 183. Okay. QRSs are narrow. It's very regular. You really can't see any P waves. You see the QRST, but you can't really see P waves in there. And it's faster than 150. So in ACLS land, we're trying to show you an SVT, a supraventricular tachycardia. In real life, of course, you can have sinus tachycardia that is faster than 150. And conversely, you can have an SVT that's slower than 150 in real life. But in ACLS class, for our purposes, 150 is our general arbitrary cutoff. If we're showing you what looks like a sinus tach, but it's faster than 150, we're trying to show you SVT. And the treatment for SVT is vagal maneuvers. And if that doesn't work, then we use adenosine. If we show you this rhythm, or even this slower rhythm, which is still kind of fast, or we even show you this rhythm, which we've gone from SVT to sinus tach to a normal sinus rhythm, but I tell you the patient has no pulse, then the algorithm we're in is PEA, pulseless electrical activity, which means the heart is creating electrical complexes, electrical activity, but it's not translating into mechanical pumping of the heart. So PEA, you've got to consider your 5H's, 5T's, your reversible causes, and you've got to do CPR and give epi. And finally, we will show you one last one, which will be this one. Okay, now we're talking about paced rhythms. And paced rhythms are going to be identified by a spike followed by a wide QRS complex each and every time. So this is actually a ventricular paced rhythm. So the pacer is going to be on. It looks like it's functioning because consistently you're seeing QRS spike or pacemaker spike followed by a wide QRS each and every time. If this is created by a transcutaneous pacer, it looks like you've got electrical activity, you've always got to double check your patient and make sure there is mechanical capture as well. And the patient should have a pulse at a rate of about 79. Okay. And I want to show you one more. If during resuscitation of a patient, CPR is in progress and you see this on the monitor, this is simply a reflection of chest compressions occurring. This is CPR in progress. If there's any concern, hold CPR, look at your monitor, and check for a pulse. Okay, and always remember, CPR needs to be high-quality CPR. Okay, one last review of the deadly rhythms. Okay, deadly rhythm number 1, but the one we can do something about is Vfib. Deadly rhythm number 2 would be this one, which is VTAC, and we'll call this VTAC without a pulse. If there is no pulse, you treat this just like you would in the Vfib algorithm. This rhythm has no pulse. The patient does not have a pulse. Therefore, this is PEA, pulseless electrical activity. You've got to do CPR, give epi, and find the reversible cause to treat this. And finally, here we go with flatline asystole. There is no electrical activity. There is no cardiac output. You need to confirm it in a second lead. Do high-quality CPR and give epinephrine per the protocol, per the algorithm. All right, and we'll finish up the class with the final normal sinus rhythm, because when we're resuscitating a patient, we certainly want to return them to a normal sinus rhythm with a pulse. And this concludes our review of EKG dynamic rhythms off the cardiac monitor. These are the same rhythms that you're going to see during ACLS class. Again, this was a preview of material that you can view and study for before attending ACLS class. This will hopefully facilitate learning, get you ready for ACLS class so that you can understand the concepts and identifying rhythm to algorithm, and hopefully make learning a lot easier and much more enjoyable for ACLS class. Thank you for joining us today, and good luck with ACLS.